Hello everyone, this is Dr. Sangeeta Chaudhary again. I welcome everyone to my lecture class. In my today's class, I am going to talk about the treatment regimen for drug-resistant tuberculosis. In my previous class, I have already talked about the treatment regimen for drug-sensitive tuberculosis. Basically, the guideline of the treatment for drug-resistant tuberculosis, which I am going to discuss, is laid down by National Tuberculosis Elimination Program, Ministry of Health and Family Welfare, Government of India, National Health Mission. So let's discuss about the. Now let's talk about the type of drug resistance. Before we talk about the types of drug resistance, we need to know the different drugs. We will know different drugs which will define the various types of drug resistance. So first line anti-tubercular drugs, among which we have isoniazid, rifampicin, pyrazinamide and ethambutol. These are the four first line agents against tuberculosis that we already know. And the other drugs which will define the drug resistance are second line injectables. Second line injectables include amikacin, kanamycin and capreomycin. These are the aminoglycosides, okay? And second line fluoroquinolones. Second line fluoroquinolones includes levofloxacin, moxifloxacin and getafloxacin. Okay, we know about drugs. Now let's see what are the types of resistance pattern. There is something known as isoniazid monoresistance or polydrug resistance tuberculosis. As the name suggests, isoniazid monoresistance means a particular strain of Mycobacterium tuberculosis is resistant to isoniazid. Polydrug resistance means the particular strain is resistant to against isoniazid plus one of the first anti-tubercular agents but not rifampicin. If the strain is resistance to both isoniazid and rifampicin, it is known as MDR. Okay, resistance to isoniazid plus rifampicin is known as MDR. Okay, so that is the difference between polydrug resistance and multi-drug resistance. Polydrug resistance means the resistance against isoniazid plus any of the other first line drugs except rifampicin. Then that means isoniazid plus pyrazinamide or ethambutol. Okay, if the strain is resistant to isoniazid plus pyrazinamide or ethambutol, it is known as polydrug resistance. But resistance to isoniazid and rifampicin, if it is there, it is known as multi-drug resistant tuberculosis. There is something known as XDR. XDR mane extended, okay, extended drug resistance or extensive drug resistance tuberculosis. Okay. So extensive or extended drug resistant tuberculosis means the particular strain is resistance to isoniazid plus rifampicin plus the second line injectables we have talked about plus any of the fluoroquinolones. So resistance against isoniazid plus rifampicin plus any of one of the second line injectables and any one of the fluoroquinolones means extensive drug resistant tuberculosis. RR stands for rifampicin resistant tuberculosis. That means the particular strain is resistant against rifampicin. So these are the. Now let's talk about the drugs or drugs regimen against drug resistant tuberculosis. So to know about the regimen, first of all we need to the drug grouping, okay, for the treatment for which we use for the treatment of drug resistant tuberculosis. Group A means quinolones, fluoroquinolones that contains levofloxacin, moxifloxacin, getafloxacin. Second line injectables I have already talked, amikacin, capreomycin, kanamycin, streptomycin. And other second line agents includes ethionamide, prothionamide, cyclosarin or terizidone, linezolid, clofazimine. Group D contains add-on agents. They are not part of the core MDR TB regimen, but they can be used as add-on agents. D1, okay, contains pyrazinamide, ethambutol, high-dose isoniazid. D2, bedaquiline, delamanid. D3, para-aminosalicylic acid, imipenem, cilastatin, meropenem, amoxicillin, clavulinate, thiocetazone. Okay, so these are the drugs which can be used in combination against drug-resistant tuberculosis. So let's see the standard drug regimens for drug-resistant tuberculosis laid down by NTEP, that is National Tuberculosis Elimination Program. So I have already talked about isoniazid monoresistance or polydrug-resistant tuberculosis. Okay, so what is the regime for this group of tuberculosis patients? For them, we use this regime, that is 6 months. This 6 denotes for the duration 6 months of levofloxacin, rifampicin, ethambutol and pyrazinamide combination. There will be nothing like any intensive phase or continuation phase division, but we use these 4 drugs altogether for 6 months, okay, for these group of resistance. Okay, now coming to the treatment of MDR or rifampicin resistant tuberculosis. For these group, we have 2 regime, shorter regime, okay, and the other one is longer regime. What is the difference between shorter regime? Shorter regime is usually for 9 to 11 months. Okay, that is about the shorter regime. Whereas the longer regime is for 18 to 20 months. Okay. And if we talk about the drugs, in the shorter regimen, there is injectable agents, okay, injectable agents, second line injectable aminoglycosides, but in the longer regimen, there is no injectable agents used. Okay, so what is the shorter regimen? Shorter regimen will have an intensive phase, okay, and a continuation phase. Okay, so 4 to 6 months of intensive phase, which in which we use moxifloxacin high dose, kanamycin or amikacin, ethionamide, clofazimine, pyrazinamide, high dose isoniazid and ethambutol. So these are the 7 drugs we use for intensive phase of 4 to 6 months for MDR or rifampicin resistant tuberculosis. For continuation phase for 5 months, this number denotes denotes the duration of the treatment. So for 5 months, we use high dose of moxifloxacin, clofazimine, pyrazinamide and ethambutol. If we talk about the longer regime is of 18 to 20 months. In this, we use these 5 drugs: bedaquiline, levofloxacin, linezolid, clofazimine and cyclosarin. Okay, so in this, again, in the longer regimen, there is no division like intensive phase and continuation phase. Altogether we use all these drugs. Okay, bedaquiline should be continued for first 6 months, that is the thing. Okay, and the other drugs can be continued, and linezolid dose should be reduced after 6 to 8 months, that is important. Lastly, bedaquiline containing shorter regimen is also there. Bedaquiline is one of the 2 newest drug for which are developed against drug resistant tuberculosis. Okay, bedaquiline and delamanid are the 2 drugs which are discovered or developed after 40 to 50 years of the development of rifampicin. Okay, so bedaquiline containing longer regimen we have talked about. Bedaquiline containing shorter regimen is also there, and it is yet to be introduced everywhere in India. I mean, it is not introduced in all the states of India till now. So 4 to 6 months of intensive phase and then 5 months of continuation phase. So 4 to 6 months of intensive phase, we will use bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose isoniazid and ethionamide. These are the 7 drugs which are to be used in this shorter bedaquiline containing regimen. But just remember that bedaquiline to be continued for first 6 months of the regimen. And the continuation phase, okay, the continuation phase will contain levofloxacin, clofazimine, pyrazinamide and ethambutol. These 4 drugs. These drugs will be given in the 5 months continuation phase. Okay, so this is all about the regimens of drug resistant tuberculosis I wanted to talk about in this class. I hope I could make it simpler, and thank you so much for your patience hearing.